They ride tricycles in the hallway, not in the park. They know the names of their chemo, not their schoolmates. It's their laughter which touches one's heart, and it's their strength which makes an adult cry. That's what's true of children growing up with cancer. Welcome, ladies and gentlemen, to the program Dr. Tapaswini's Corner. That's me, and I work as a head and neck cancer surgeon. Nothing is more painful than watching one's child struggle through a cancer treatment just to have a chance at life. Unraveling the facts about childhood cancer, we have our expert today, Dr. Gauri Kapoor. You are the medical director of Rajiv Gandhi Cancer Institute and Research Center, Niti Park, Delhi, and also the director and head of the pediatric hematology and oncology. Trained at the Tata Memorial Hospital, Mumbai, and the St. Jude Children's Research Center, Memphis, USA, you have more than 30 years of clinical experience dealing with leukemias in molecular oncology and stem cell transplant. Welcome, Dr. Gauri, to the show.
Hello, Dr. Tapaswini. It's a real pleasure to be here on your chat show, and I'm sure we'll have some interesting discussion which will be useful to our viewers as well as our listeners.
Thank you so much for spending some valuable time of yours today for the program. So broadly, when we say childhood cancers, what is the age group that we are referring to?
So this is a really interesting question because different people across the world have different cutoffs. But generally, it is believed that both childhood and adolescent cancers should be treated on pediatric protocols. Right. The American Association of Pediatrics, they take it up to 21 years, while the Indian Academy of Pediatrics for the last 20 years have considered 18 years as the cutoff. It has also been seen that adolescents treated on pediatric protocols for cancer do exceedingly well, and they do better than when treated on adult protocols. This, in fact, is published in the Journal of Clinical Oncology.
Okay. How common are these childhood cancers?
As you well know, cancer is actually or essentially a disease of adults.
Right.
Pediatric cancers are believed to be rare conditions.
Mm-hmm.
Having said that, globally, about 3 to 5% of all the cancers are pediatric cancers.
Mm-hmm.
If you look at the incidence, it's about 150 per million children.
Okay.
So it's a rare disease, but it has excellent outcomes and it's worth focusing on their treatments.
So what are the various childhood cancers which we get to see in our clinical practice?
Childhood cancers are quite different from the adult cancers. The most common cancers in children are the leukemias and lymphomas, which have excellent outcomes.
Mm-hmm.
The leukemias are ALL and AML, and in children, 75% of the leukemias are constituted by acute lymphoblastic leukemia, which have cure rates like 70 to 90% long-term.
Well, that's excellent. Yeah.
Right. The AMLs are less common. They are more common in adults. The biology of the leukemia also is supposed to be such in children that it responds very well to treatment.
Childhood cancers,
yes,
vis-a-vis adult cancers, are they really biologically very different?
They are totally different. The childhood cancers arise from immature or blast cells. So other than the leukemias, we have the lymphomas, and then we have the brain tumors and solid tumors like the neuroblastoma from adrenal, the nephroblastoma from the kidneys, the osteosarcoma and Ewing sarcoma from bones, hepatoblastoma from the liver, retinoblastoma from the eye, and so on. While in the adults, we have what we call epithelial cancers from mature tissues like cervical cancer, lung cancer, prostate cancer, breast cancer. We don't get these cancers in children. So the disease is different, and so the treatment is very different.
Okay.
They are fast growing. They require immediate attention.
Mm-hmm.
The children tolerate chemotherapy also very well because they have healthy organs.
Right.
So
perfect.
We are able to deliver intensive treatment, which their disease deserves, and therefore the outcome is excellent.
That's a big respite, to all the parents and the caregivers of these children. That gives a lot of optimistic outlook to the treatment also. Yeah, as the cancers, as we say, the symptoms are so very innocuous that we tend to confuse them with other benign diseases. What are those warning signs that we all should be aware of?
So you're absolutely right. There is no unique symptom for cancer. Cancer is a group of different diseases. Each one has different symptoms, but there is no unique symptom which identifies a disease to be cancer. So it can mimic common childhood illnesses. So, when children are growing up, they have lumps, bumps, they fall here, they have growth spurts, they have mood swings. And with all of this, it often becomes difficult to dwell on a particular symptom and think that it is serious. But you also know that we can have excellent survival with childhood cancers only if we diagnose it early and on time and we treat it properly. Therefore, as you rightly said, for the lay public as well as for the practitioner, it is very important that they identify or have a high risk of suspicion and diagnose the condition on time rather than delay the diagnosis when the disease could be pretty advanced, and then the treatment complications and outcomes would not be so favorable. So coming back to what are these common symptoms? So P is one of the words that we think, persistent symptoms, progressive symptoms.
All right.
And what could these progressive or persistent symptoms be? It could be a prolonged fever, which persists for 2 to 3 weeks. And despite treatments and investigations, there is no known cause. So it's called fever of unknown origin, which persists. It may be associated with other symptoms, not just fever alone, but it may be associated with fatigue. It may be with anemia or pallor. That means the person is looking very pale and weak. It may be associated with neck nodes, with easy bruising or bleeding, with weight loss. So a constellation of these symptoms would make one suspect that there is some problem with the blood. Okay. Because as you know, blood has 3 components, the red, white, and platelets, the red cells, the white cells, and the platelets. And these symptoms actually stem from the disorder in one of these components. Okay. So in that situation, what we say, if a fever is not responding, it's a good idea to do a complete blood count. It is a simple. The other symptoms could be neck nodes or lumps and bumps anywhere in the body, which is unexplained. It could be in the stomach, it could be in the pelvis, in the testes, arms, legs, head, neck, anywhere on the body, which is increasing in size, which has no known cause. Often one gets an injury and that directs one's attention to that swelling, but it is probably not the cause of the swelling.
Okay.
Initially, these lumps and bumps are often painless. They're often painless, but later on when they impinge nearby structures or nerves, they can become painful. So unexplained lumps and bumps. Then we can also have a white reflex in the eye. Inside the pupils are usually black. It shows like a white reflex, also looks like a cataract. In young children, it could be a retinoblastoma. Other than that, any change in vision, any squint developed, any new neurological symptom, like a delay in developmental milestone or a regression of milestone or a weakness of an arm and leg or a severe headache, which is persisting and which is often associated with vomiting. But if there is a combination of these, if these symptoms are persisting over 2, 4, 6 weeks and they are not resolving despite medical attention, then it is time for us to think, can this be cancer? And then what kind of cancer could this be? And what investigation should I therefore advise the family?
Having cancers at such a young age, what are the probable causative factors?
Right. So there's a tremendous amount of research, molecular oncology research that is happening in cancer and also in pediatric cancer. We know cancer is a complex disease. We know that within the cancer cells, there's a lot of DNA change, genetic abnormalities. But it does not mean that cancers in children is inherited. More than 90% of cancers in children do not have a known cause, despite all this tremendous amount of research that is happening.
Mm-hmm.
And I will suggest that we can even say that it is usually not inherited, it is not hereditary, it doesn't run in family. Mostly it is what we call a genetic accident. So we say it is by chance in more than 90% of the cases. In adults, we know there are environmental factors, like smoking predisposes to lung cancer, tobacco chewing predisposes to oral cancer. We also know chronic alcohol consumption can cause esophageal cancer. So such environmental factors are not evident in pediatric cancers. There is no obvious known cause in more than 90% of the cases. It does not run in families usually.
But is there any role of, the immune system being weak in these children, or any role of radiation exposure, chemotherapy-induced second primaries, or radiation-induced second tumors, or advanced parental age? Does it influence that the child may have, some cancer later?
You're absolutely right. These can cause cancer, so very high exposure to radiation, certain drugs like alkylating agents. So these could be, we can say, secondary cancers. So you are using radiation or chemotherapy to treat one cancer, and certain subset of children might develop a second cancer due to these exposures. But by and large, so there are even, by and large, like I said, 90 to 95%, you won't be able to find a cause. But in the rest, there may be radiation exposure or drug exposure, or even, in fact, very few families in the world called familial cancer syndrome or Lee-Fromeni syndrome, they are predisposed to cancer, and immune deficiency syndromes, the primary immune deficiency syndromes, ataxia telangiectasia, babies with Downs. Right. These have a higher predisposition, but the total numbers would be very few. So there are rare syndromes. In those syndromes, there is actually a guideline for screening these children. But by and large, 90% would not have any identifiable etiology.
Somewhere there is a role of genetic studies. When we are looking at childhood cancers, there is some role of genetic studies in them. Probably would help select a certain patient group who may be at a high risk.
Once the cancer is diagnosed, in that situation, there are certain constellation of features which would suggest that we recommend genetic studies for these children. Like somebody has a bilateral retinoblastoma in a very young age. We would clearly say, please get your other child screened. Then if there is a family history of breast cancer in young women in the family, then we would advise for the P53 genetic test to be done. So yes, there are certain identifiable genetic abnormalities which have a predisposition for cancer. And if the child fits into that clinical constellation, we would advise genetic counseling in those.
Right. So if you look at the investigations, what are the battery of investigations that you run on these little children to diagnose them?
So there are two broad headings under which we would investigate the child. Number one would be to confirm the diagnosis, and the two would be to stage the disease.
Right.
So what about the diagnostic tests? Diagnostic tests are routine tests, like a suspected leukemia would be a complete blood count. And if in the blood count, we see that one or two cell lines are abnormal, by abnormal, I mean it could be a low hemoglobin, a low platelet, a low white count, or a very high white count, I would advise a peripheral smear examination and a bone marrow aspiration test. So for leukemia, that would be a standard initial battery. For lumps and bumps, I would do an imaging. The initial imaging, if it's in the abdomen or pelvis, would maybe just be an ultrasound, like a screening. And if there is a lump or there's a mass, then I would accordingly go further. If it's an extremity mass, like on the leg or on the arm, then I would just get a plain X-ray initially to see what is there. And subsequently, of course, like a CT or an MRI. Thereafter, the lump and bump would require a biopsy. And the biopsy and its histopathology report would then tell me, is this a cancer or is it a benign disease?